friends and colleagues. Some years ago, I was in the WHO or World Health Committee for guidelines, and I asked the chairman of the committee, do psychiatrists read guidelines? He smiled and shrugged his shoulders. Recently, I asked a GP for his comment in the last guidelines, and he told me that certain areas are rather vague and rather amorphous. And I explained to him that guidelines are not meant to be cut and dried. In some countries, for example in Australia, in America, and also in Britain, they have guidelines for primary care, guidelines in general hospitals, guidelines for special clinics. But here in Singapore, we have one for all, but hopefully we'll guide you through some areas that are probably appropriate for family medicine or primary care, and some more appropriate in the general hospitals. My task today is to clarify some issues if you have gleaned through the guidelines, mainly on screening and assessment. The first question that comes to your mind would be, why screening? Why is there a need to screen elderly people with dementia? Mainly because in primary care, it takes a long time before you come to a diagnosis, even in the tertiary or secondary hospitals. And dementia is a very powerful diagnosis because it means in terms of mental capacity, there are issues on testamentary capacity, whether a person can make a will, and issues of finance. So we are very, very careful. And also sometimes when you do screening, because you want to do a research, you do a study around here in Outram area, a study you see on Parkinson's disease, you know the prevalence is very small. You have to do a screening first, a two-phase design in research. I've trawled the literature in the world, and there are about 20 screening questionnaires used. But here in Singapore and in this part of the world, there are few which are commonly used by various doctors. Firstly, it's the mini mental state. The mini mental state was constructed in Johns Hopkins almost in late 1960s. And it's been used very commonly in many countries. And I'm sure in this room, I'm the person who first used the mini mental state in 1977. 30 years ago, I was working in England, and they wanted to restructure the hospitals in England. They reckon a huge hospital like we have in IMH or Woodbridge, a big warehouse, is not the way that hospitals should go into. So we're supposed to break down to smaller hospitals, and some for dementia, some for depression. So my role was to help them to assess and categorize the patients. But after seeing 5 patients, I told the consultant psychiatrist in Oxford that it is impossible for me to go through because there's a timeline of 3 months. It will take me another 6 months to finish, and training program with 6 months rotation. I told him it's impossible because it will take me about 25 minutes to administer the mini mental state. And also, if you ask your own practice here, I don't think you have more than 25 minutes to see one patient. The GP whom I talked to earlier on told me he sees a patient for about 15 minutes. So an instrument that takes about 20 minutes is not applicable. Some years ago, here in Singapore, the NNI director was Richard Johnson. Richard Johnson works with Marshall Falstein. Marshall Falstein was the man in Johns Hopkins who constructed the mini mental state. And he told me he was alarmed when he came to Singapore and found that lots of hospitals and even primary care, they're trying to use the mini mental state. Because if you read the opening paragraph of the research paper written by Marshall Falstein, he'll tell you that the instrument is better for the Anglo-Saxon population and those who are educated. If you read the column on the mini mental state, they want you to spell the word world backwards. And many often in Chinese, there is no spelling at all. It's almost impossible. In hospitals, sometimes in research, we use the mini mental state because we want to publish the paper in American journals. So, but we also in hospital, we have research assistants to help us. But if you are working in primary care, it's very difficult. So in England, I used the AMT, the abbreviated mental test, which is also used in some hospitals here, which I think is good, but also about 30 questions for you to plow through. The third one is the Informal Questionnaire IQ code, constructed by somebody I know in Australia called Anthony Joms, and it's an instrument you use by the caregivers. You ask the caregivers to ask some questions, to answer some questions, and about 30 questions, if they score beyond certain points, there's the possibility of dementia. So it's fairly good. The caregivers may have some time to go through. But sometimes we also we try it out with our patient in NUH. The complaint to us is too long. The fourth one used commonly here also, the Elderly Cognitive Assessment Questionnaire, is a local brood, a local born conceived here in Singapore, part of the World Health Study. I'll go through it later on. But before that, I'll just go through something on the prevalence, which are relevant to the guidelines. In 1990, 17 years ago, our department published a paper on the prevalence of dementia and gave the figure of 2.5%. And the paper was sent to a British journal. It was rejected by British journal because the editor told me that it's impossible because the most influential psychiatrist in Britain was Sir Martin Roth. And Martin Roth has published a paper previously and stated categorically that the prevalence is 10%. In all the textbook of medicine in the UK. And it was eventually published in an Australian journal. Then part of the coordinator for the World Health Study on this part of the world 17 years ago. And other figures in Asia found the same. Among the Chinese population, about 5%, 3 to 5%. These are the Malay study here in Singapore, and the Indian study from India. It's an Asian study. And as you eyeball this slide, you know the prevalence is about 5%. Okay? This is very important because if you use 10%, then the Ministry of Health extrapolation in terms of estimated number of patients will go haywire. I'm not too sure the figures are put up was the right figure earlier on by Dr. Chong. If you use 10%, you blow it up and you have to build more day centers when in fact you're over providing. But that was the figure, and now in all textbooks of medicine they agree it's 5%. I was asked to present the figure at the UN conference in New York some years ago. But from the figures of 5%, we can extrapolate and say today, maybe not in terms of 22,000, maybe of 9,000. About 9,000 somewhere in the community. I've tried to ask my RA to ring up all the day hospitals, the clinics in Singapore, the homes in Singapore. We only came out to about 900. So what happened to 90%? Mainly because they've seen primary care doctors, and some of you will say that, well, that seems like normal aging. We have many generations of doctors who have gone to medical schools who haven't been taught geriatric medicine. So it's very difficult for them in primary care now to diagnose dementia at first hand. And probably it's better to do a screening. And so from the World Health Study that we had about 17 years ago, with massive data of over 1,000 elderly people, and with the collaboration of World Health, we extracted out 10 questions which were predictive of dementia. And from there, we came out with the Elderly Cognitive Assessment Questionnaire with my colleague Ho Su Ming. It's published in American and the European journals, and we use extensively this part of the world. Yesterday I was in Malaysia for a conference, and they use it in Malaysia. The Minister of Health has decreed that all Malays above 60 who are going to Mecca for their pilgrimage must have the ECAQ done, because they found that some of the elderly people go to Mecca on a dry desert sand, they develop delirium, and they realize in fact they have dementia. So everybody must go to this questionnaire before they can go to Mecca. I was telling Dr. Koh that if we have taken a patent on this and they pay us $10, we can all retire now. Yeah. Okay. But we've done this. We've asked our neurologist. Is there a neurologist in the audience here? And the neurologist in NUH said, there's 10 questions. That's too many. Neurologists, we just want 5 questions. When you use the tendon hammer quickly. Well, we say, so we negotiated with them. They know must be 10 questions, too many. So we have assembled a team of 4 years ago. This instrument probably is better for people with moderate to severe dementia. We've assembled a team to study early dementia and whether we can use it for the families. And it has been published 4 months ago in the American journal, Informal Questionnaire, about just 5 questions. And I think it's available in the reference. It can be administered by the family caregivers as a screening, not as a diagnosis. Then you can screen through, you go through, it is scored 4 points, 3 points out of 4, and you have a high index of suspicion, then you go back and assess them again and need to refer to a specialist for a second opinion. My modus operandi with my colleagues in primary care and primary practice and colleagues in the region is after they refer to me, we done all the assessment and management, and when the patient is stabilized, I send the patient back to the family physicians or to the doctors in the region and tell them that I'll review the patient for you maybe once a year. And you can see the patient every two monthly or 6 weekly, or else there'll be a backlog of patients in our clinics.